All right, welcome back. And we're going to finish this hour by discussing clinical use of drugs and actually what we were mentioning in the last lecture about the difference between the sexes and ages is relevant to this topic. So again, in terms of the objectives, and some of these you already know, in terms of the general principles, mechanism of action of drugs, receptors, some definitions that I'll go over again: potency, specificity, selectivity, tolerance, and we'll discuss the age, sex differences in terms of drug response, as well as placebo effect, which is a very important aspect of treatment. So, as you know, a drug is defined as a substance that can cause physiological changes, and the idea of any drug is to bring in the maximum effect and minimal side effect. So, meaning to be right on the target. This is an ideal situation, of course, but in reality, it's not attainable. There is always some risks with any drug, and the idea of treatment is to have this balance, or once the benefit outweighs the risk, then that's where you want to go. And fortunately, some drugs have a lot of benefit, very small amount of risk. Some have substantial risk, but again, still the treatment is worth doing. In terms of pharmacology, 90% of whatever we do in pharmacology is dependent on the dose, concentration. And as a general principle, you might already be familiar with this, that too much of a drug can be harmful, whereas too little cannot be effective. So you want a therapeutic index where the drug manifests its effectiveness. So therapeutic index is defined as relative safety of a drug, and the larger the therapeutic index, the safer it is. Now, there is this concept of hormesis, that any poison, not any drug, but any poison in very small amount can actually have some beneficial effect. And this concept was developed by Calabrese, and there is a good paper on that. And the best example I can give you is botulinum toxin. That is a very poisonous, toxic agent. However, very low concentration, as you might have heard, in Botox, that is used in cosmetically to reduce the wrinkles because it causes relaxation of the facial muscle, and can also be therapeutically used in migraine, overactive bladder, and so on. So the idea that a poison can be having actual therapeutic effect is not uncommon. You have this thallium heavy metal that can be used in imaging, and actually arsenic, a heavy metal. This is an interesting history. It's a king of poisons and poisons of kings. They used to use these to basically get rid of the enemies. And in 1909, the German Nobel Prize winner Paul Ehrlich used derivative of this arsenic for treatment of syphilis, and this eventually became the concept behind chemotherapy. So again, using the agent in the right amount, right condition is what pharmacology is about. And in terms of drug effectiveness, potency, when we talk about potency, it's really defining the concentration. So the more potent the drug means the less concentration or dose would be effective. And there is also the concept of specificity and selectivity. A drug is considered specific if it acts on a receptor that is specific to one tissue. So specificity is concerned with a specific tissue, whereas selectivity is concerned with selective receptor. So when you said a drug is selective, for example, it's just for alpha-2 or for muscarinic M4 receptor, or et cetera, et cetera. So in terms of the selectivity that a drug would just act on one receptor, this is practically uncommon or unattainable in pharmacology. Any drug might have multiple targets, and sometimes, honestly, the dirtier the drug, when we have multiple targets, can be more effective because it might affect the process of the disease in several stages. And the reason we do not have much or specificity or selectivity is because you have overlap of circuitries, neurotransmitters. Like, for example, you have here the pathways for different neurotransmitters, and there is some overlap. So when you try to affect one, inadvertently, you can affect the other as well. And one specific example that I'll concentrate on is the cholinergic system, acetylcholine, which is very important, as you know, in cognitive functions, right? So acetylcholine, as you know, has its own circuitries, and it's one of the first neurotransmitters that gets affected in dementia. And the idea is to increase the level of acetylcholine. The way to do it is to give acetylcholinesterase inhibitor to keep more of the acetylcholine in the synapse, because as you know, acetylcholine gets broken down very quickly by cholinesterase in the synapse. So the idea of cholinergic intervention in Alzheimer's is more or less similar to dopaminergic intervention in Parkinson, where there you know there is inadequate dopamine transmission, so you give a dopamine agonist or precursor of dopamine L-dopa that gets transferred to dopamine, and you get relief of symptoms. Now, in terms of the acetylcholine, remember that it is a transmitter that is involved in both sympathetic, parasympathetic, as well as the sympathetic system. And without going into too details, have the this is really like a review slide. You see that in terms of the neuromuscular junction, acetylcholine, there, of course, you have the nicotinic receptors. Remember, acetylcholine, you have two different types of receptors. There is the muscarinic, that is G protein coupled receptors, and you have nicotinic, that is ligand-gated ion channel. And the difference between these two receptors is that the ligand-gated ion channel is a very fast, because you bind the receptor, the channel opens, and you get the flow of ions, whereas the G protein coupled receptors, you have to go through the second messenger and cyclic AMP, etc., that eventually brings about the effect, but it's slow compared to the ligand-gated ion channel receptors. Still very fast, but compared to the other one is slow. So in terms of the functionality, you know that you have the synthesis of acetyl-CoA, eventually acetylcholine in the vesicle gets released into the synapse and gets broken down by acetylcholinesterase. And here you have the cholinergic nicotinic receptors, and then you also have the muscarinic receptors that, as I mentioned, are G protein coupled receptors. So again, in terms of the difference, you see the ligand-gated ion channels. They are subunits that basically form a pore, and once the ligand binds, opens the pore, and you get the inflow of ions or outflow of like inflow of sodium and outflow of potassium. Now, the G protein coupled receptors, which would be representative of muscarinic receptors, these span the transmembrane, 7 domain receptors, and again, you have the second messenger that can be stimulatory or inhibitory eventually. And again, you have many different receptor subtypes. For nicotinic receptors, if I can go back, you have these subunits that combine to make the receptor. These subunits are really what causes the muscle to contract. The neuromuscular junction is full of these nicotinic receptors. Without them, you won't have any muscle contraction. And in fact, curare that paralyzes is to inhibit these receptors, basically. So in terms of the composition, you have these receptors in the neuromuscular junction, you have them in autonomic ganglia, and you have them in the brain. But the subunit composition of these are different in each area. In muscle, you have this delta and epsilon, whereas in the brain, you just have alpha and beta. Anyways, once you have these ligands connected, or simulated, you get the final effect. In terms of the muscarinic, you have 5 different muscarinic receptor subtypes localized in different tissues, different function, and this brings the complexity of when you talk about selectivity of specificity, that one transmitter with so many different receptors, different areas can have so many different functions. This is depiction of the muscarinic, and same thing kind of with nicotinic. You have the nicotinic receptors in different areas of the brain. Actually, we know there are some pathways in the brain that are associated with reward. When you stimulate this pathway, you feel the pleasure. And that pathway is referred to as mesolimbic pathway that starts in the ventral tegmental area and goes into the ventral striatum or nucleus accumbens. So any which way you stimulate this pathway, you get the feeling of pleasure. And it is due to the release of dopamine in the terminal area. And all drugs of abuse basically affect this pathway, but in different ways. For example, cocaine inhibits the uptake of dopamine, whereas nicotine stimulates the release of dopamine. So eventually in both cases, you have an increased level of dopamine in the reward pathway, this mesolimbic, that you get the feeling of pleasure. And so knowing that these drugs can affect these, they become addictive drug, of course, with a lot of side effects. So again, the concept of too much or too little of a drug, and the same thing if you have too much of release of any neurotransmitter or too little can be problematic. In terms of acetylcholine, what we are discussing, excess can cause cramps, increased salivation, lacrimation, urination. That's why anticholinergics are used to reduce salivation, reduce uterine contact, the urination frequency, lacrimation, so excess cramps, increased salivation, lacrimation, urination, diarrhea, muscle and respiratory paralysis. And actually, this respiratory paralysis is what is induced by nerve gas, organophosphates, and basically they are acetylcholinesterase inhibitors. So when you have too much acetylcholinesterase in the respiratory tract, it can cause paralysis, stopping breathing, and death, of course. On the other hand, if you don't have enough acetylcholine, you, as I mentioned, the Alzheimer's disease is one of the manifestations clinically, and in terms of the peripheral myasthenia gravis, the inadequate muscle strength and all that is due to inadequate acetylcholine. So the different receptors, different pathways, on top of it, the genetics and epigenetics can become some sort of issues in terms of specificity and selectivity. Now, knowing what the neurotransmitter does, and if there is excess, how we can treat, if there is inadequacy, how we can treat, that's very important. And this gives us some specific tools for specific cases. For example, atropine, which is a muscarinic antagonist, can be used for pupil dilation. You go to a ophthalmologist, they always use that to look into the eyes. It's an, as I mentioned, muscarinic antagonist. It acts through the G protein coupled receptors and basically affects muscarinic receptors, also interacts with histamine and serotonin. Again, no specificity or selectivity. So we strive to have sometimes these selective or specific drugs, but unfortunately, they are not always attainable. Again, I mentioned that sometimes the dirtier the drug, the less specificity or selectivity might be more advantageous. And here I have a table of different drugs that were developed for some specific cases, and then they found out to have another useful indications. For example, amantadine was developed as antiviral, but then has anti-Parkinsonism as well, or various other compounds that I won't go into. So anyways, you have, in terms of drug interactions as well, for example, sildenafil, which is Viagra, it was first developed as antihypertensive drug, but then later on, this is one of the most prominent example of non-specificity or selectivity that becomes very useful for another condition. Same thing, you have phosphodiesterase inhibitor that causes increase in nitric oxide and can be used as a vasodilator. And this Viagra, as you know, is used for erectile dysfunction and or pulmonary hypertension. But because this can affect the cardiac tissue, specifically causing vasodilation and decrease in blood pressure, it's something to be concerned about. Again, useful for one, but be cautious of the side effects. So there is also, in addition to the diversity of receptors and pathways, tissues, etc., you have both genetics and epigenetics that can affect the effectiveness or usefulness of any drug. So the genetics, as you know, is the sequence of the DNA that determines the specific protein manufactured and the effect of the drug on the final product or the DNA. Epigenetics does not affect the sequence, except it affects the expression of the genes by affecting the methylation or acetylation. So this situation leads to what we call idiosyncratic reaction, which means really an abnormal response to a drug. In dentistry, most falsely described idiosyncratic reaction to local anesthetics are the result of accidental intravascular injections or anxiety reactions in the practice of injection. So you say, oh, it's an idiosyncratic reaction, which can really be there, but sometimes it is not an idiosyncratic, but due to the actual effect of the drug because of the side effects, basically. So in some, you have specific, well, I should say specific, non-specific reactions to specific drugs, basically, that become idiosyncratic, that you don't know the cause, but it is a different reaction to the drug in some than what you expect. And I have given some of the examples. One such thing, due to genetic abnormality in NADH, you have benzocaine or perlocaine, that the idiosyncratic response is the methemoglobinemia, which is a purple or blue skin, lip, or nails. So idiosyncratic due to the genetic variation and a different unexpected effect of a drug. A couple of other important terminologies. One is tolerance. As you know, many drugs, the more you use, the less effectiveness you get. And this is, of course, very readily manifested with tolerance to the opiates, tolerance to alcohol. And the reason is that you develop either desensitization to the receptors, of the receptors. The more you use, the more desensitized the receptors, so you need more of the drug to have the same effect, or you have enzymes that are induced by the drug. For example, alcohol, very highly enzyme inducer, breaks down the drug faster, so you need more to have the same effect. That's why with the alcoholics, basically, you have to have much higher consumption to get the same effect compared to the initial use. And that's because it's being broken down. Basically, the idea of tolerance is that you have less effectiveness with the continuous use of the drug, and you need to increase the dose. And resistance is in the same kind of idea that you might not have as much of effectiveness. So for this reason, you use combination therapy, specifically in terms of the treatment of tumors, cancers. You have multiple drugs to overcome the resistance, not so much the tolerance, but the resistance to one drug. Or you can call it tolerance as well. But anyways, basically, specifically for cancer cases, you have this multiple drug use to overcome these conditions. And the same thing when you have renal failure, you cannot, or even liver damage, because the liver is causing the breakdown of the drugs, toxicants, and kidney is getting rid of the toxicant. So if you have problem with the liver or kidney, you can accumulate the toxicants and can cause, of course, severe adverse effects. So this becomes an issue with any of these cases in terms of the drug treatment and not causing toxicity due to inadequate functions of these organs. Adverse or side effect, as I mentioned, there is practically no drug without side effects, and combination therapy might actually be useful in that you can cancel the side effects. Sometimes it's the opposite. When you put more drugs, you have more side effects. But this should not be a general principle that you cannot combine drugs. No, because sometimes combining, you can actually cancel the side effects. And so there is some hesitancy in many cases to combine drugs because of the fear of the side effects. But if you look deep into the pharmacokinetic dynamic interaction of drugs, then it becomes actually beneficial to combine the drugs. So beware of this condition and not to be afraid of combining drugs. And then there is more drug and side effects, etc. I won't go into just for you to be familiar with. Now, few things in terms of the drug therapy or treatment, in terms of geriatrics, adolescence, adulthood, and pediatrics. So you have to recognize that a child is not a young adult, really. So it's a very different circuitry person. And as, of course, the development is taking place, adolescence is the period of rapid changes, many situations, adulthood, and then geriatrics or aging due to reduction in function of many organs. You have to be very careful in terms of the drug treatment because the same dose can actually become toxic because the drug is not being metabolized and so on. So here are some summaries of these principles: age-related functional changes in drug disposition and cellular responsiveness. So you need to be careful in terms of the dosing, scheduling, and effectiveness in terms of the safety. And in terms of the dentistry, specifically, geriatric pharmacology is becoming very important. And I here have some important adverse reaction, and then I'll go to age again. So in terms of the drug allergy, adverse responses of immunologic origin account for approximately 10% of the side effects, basically. Allergy can be distinguished from other forms of drug toxicity in several respects. First is the prior exposure to drugs or a closely related compounds is necessary to elicit this reaction. So you have exposure and then later you develop allergic reactions, sometimes even in the first, but in majority it's due to repeat use. And the severity of the response is dose dependent, and the nature of the unfavorable effect is due to the immune mechanism. So when we talk about allergy, it's really the response of the immune system to the pathogen, whatever it might be. And sometimes you get very severe second reaction, like sometimes when you have a antibody, first time you develop, and the second time you get that insult, you have a much more severe reaction, like in terms of these things and stuff like that. But in general, the reaction is unpredictable and it occurs in small portion of population, fortunately. And sometimes there is no concern, but it is something that can manifest in at least 10% of the patients. There is also the gender or sex difference, as well as condition of pregnancy and lactation in women, which can affect and be very important concern in terms of the drug treatment. So in terms of the sex difference, we know that women have, in general, have less body mass than men, and this can cause a different response to the drugs. And there is also a change or difference in hepatic function. And for this reason, women appear to be more susceptible to drug-induced blood disorder, or what we call dyscrasias, and those taking systemic contraceptives may be more prone to some drug interactions. So again, there is the condition of the not only body mass, but the hormonal changes that can affect the different responses between men and women. And there are some more concerns that I won't go into. But in terms of the specifically pregnancy and lactation, it's very important to beware that there could be alterations in liver and renal functions, and this can cause, as I mentioned, delay in metabolism and excretion of the substances. This can lead to hepatic toxicity, for example, of tetracyclines and and other compounds that is actually accentuated during pregnancy. So again, when present, toxemia might increase drug effects by reducing the binding capacity of the albumin to that drug. And so of primary importance are the actions of drugs on the unborn child. As I mentioned in the previous things, the prenatal exposure to drugs, especially drugs of abuse, can be very harmful to the fetus and then can be manifested later on in the development of the newborn childhood that can last throughout their life. So for this, you have to be considerate of the drug action, considering the sex, age, and the hormonal situation. So again, because some drugs may cause unwanted side effects in the nursing infants, again, it's important to beware during the lactation. Some drugs, fortunately, are safe during pregnancy and lactation, but many others are of concern in terms of their use during those times. I have listed number of drugs that can be of concern during pregnancy as well as lactation. And finally, environmental factors can be very important in terms of the drug interaction. You can have the temperature, sunlight, as you know, affect the physiological entity and the response. So, for example, children given atropine on a warm day are especially susceptible to drug-induced hyperthermia. So again, environment, drug interaction are some important consideration. And another example is the toxic skin reactions to sulfonamides, which increase with exposure to sunlight. And the diet is, of course, very important in terms of absorption of the drug and efficacy. So all in all, what we are saying is that you ought to be careful with the environmental factors. And this can be bringing some pathological condition. So diseases may influence pharmacotherapeutics by modifying drug dispositions or drug responsiveness. So if you have, for example, again, liver or kidney specifically, you can have different responses. Finally, the concept of placebo, which is a very important consideration. Two commonly held misconceptions that placebos provide nothing more than a means of placating patients. That's not really the case. And the other myth is that they may help psychosomatic illness, but are worthless when symptoms are organically based. Not true at all. And in fact, there is a very significant placebo effect that can be attributed to medication that is not related to any pharmacodynamic or specific properties. So placebo response to drug arises from expectation by the patient concerning their effects and from a wish to obtain benefit or relief. And this is very serious. It's like you can sometimes really have a placebo that becomes as effective or even more effective than the drug. So several important similarities and differences between placebo and specific effects of the drug must be remembered if clinicians are to avoid being deceived by the preparations they use. So that's why when we do a clinical trial, they refer to as placebo-controlled trial because the patient might respond just as well to the placebo. So this is a very powerful thing. And for you to remember that there is this placebo-controlled trials. So really, this is basically a nutshell what the clinical use of drugs that you have to be concerned about. Mentioned few of the concepts that I would like you to remember, specifically selectivity, specifically tolerance, and some of the drug reactions some drugs that we specifically discussed, some of the side effects of atropine, its use, and so on. And I think if you pay attention to the highlighted items, should have no problems with any of my questions. Any question? If not, then good luck with your studies and everything. Okay. Welcome.